It's my pleasure to welcome Terry Aspray to come and talk to you all about adult services for osteogenesis imperfecta. Terry.
Thank you very much. I'm just many thanks to the BBS for asking me to come. I am a local person, that's why I was slightly late. And what I'd like to talk to you about is a little bit about the local perspective on care for adults with brittle bone disease, OIM. I think you know what we're talking about. And just to recognise folks from the bone clinic, my colleagues from paediatric endocrinology, my colleagues from genetic medicine, and also orthopedic surgeons. Michael Wright, who's going to talk after me, will focus much more, I think, on genetics. The focus really, from my perspective, is to tell a little bit about what we do in the Newcastle Bone Clinic, which I think is replicated in other similar specialist metabolic bone clinics elsewhere in the country. Something about transition, which I think is a very hot topic. We have the children there, and we have the adults here, and sometime we have to get us all together in the same place, which I know we'll be doing over dinner and other things later on. But in clinical terms, how do we practice that? How do we optimize the transition from child care, child medicine, medical care, to adult care? And then a little bit about osteogenesis imperfecta in adults particularly. But again, all of this is really set in the backdrop of what we do in Newcastle. So, a quick snapshot of the 600 patients who last attended my clinic in Newcastle. About 40 or 50, I think we're up to about 65 when last I counted, adults with osteogenesis imperfecta, plus some other rare and metabolic bone diseases, and also quite a lot of experience of dealing with young adults with eating disorder who come through our service as well. So we do see a lot of young adults in our clinic, although the vast majority of patients who come through metabolic bone clinics nationally will be women past the age of menopause who are being screened and treated for osteoporosis. There's a similar kind of data. And just to highlight, these are not quite up-to-date DEXA data, which show something about the fact that DEXA isn't the be-all and end-all, and as we've heard from our orthopedic surgical colleagues, it becomes much more difficult to use DEXA as a means of monitoring care in patients, adult patients with OI, as more and more bits of metal are stuck into the bones and we have fewer reference points. So, as an adult physician, I don't treat anybody under the age of 16. Where are my patients coming from? Well, one of my difficulties is they spend an awful lot of time in paediatric services and to meet these cuddly paediatricians and gorgeous geneticists, of which you have an example to my left, and they go to this wonderful Great North Children's Hospital, which is very colourful, although I think the cladding's a bit suspicious. And they go for long walks with beautiful blonde ladies in the park, and they have great big doggies who take them for walks as well. And it's a very different environment from adult services. We also have a stream of patients who've been treated in Sheffield by excellent colleagues there, who very much twin with us. And then they come to our service, and the first kind of thing I have to deal with is expectations, and this place is really rubbish when you're used to having a games console and you're allowed to wander, you have games and it's a very different environment. And Dr. Cheatham's nurse always uses Emla cream for the bloods, and what about my parmidronate? And yes, I am taking 70 milligrams of risedronate, even though the pharmacist always questions that because it's not the adult dose. So we have all these things, and here we have a picture just before the refurbishment of what the outpatient clinic used to look like. So managing expectations is important, and again, one of the great things is that can start with my colleagues in paediatric care to help them know what to expect when they come to us. And what's the point? I guess, what's the point of coming to see an adult physician? if you've got OI, if you've got all your arms straightened with those lovely rods and you're established on your bisphosphonates, why would you ever want to see another doctor who's not a cuddly paediatrician? If you're in the room, I've disguised you as much as I possibly can. So just 2 or 3 cases of patients who've been under our care, heavily camouflaged. So Terry was diagnosed with OI, severe spectrum OI in infancy. He's a wheelchair user. He works in an office. He was getting a lot of pain and discomfort in his right leg. We x-rayed the right leg. There was extreme dislocation of the hip joint, some pseudofractures. He needed surgery. He needed a new chair. By coming to see me, those are the things we review. We review them intermittently, and he's got access to me for those concerns. When he had his last fracture in another hospital in the region, his last femoral fracture, he had to make a very big fuss, really, because nobody believed he did have a fracture within the hospital, but he knew he had because he'd experienced it before. And so again, offering some moral support to people who know their condition. There's another young woman, not quite as loud as Angie, who's in her mid-20s. She had, again, severe spectrum of osteogenesis imperfecta, diagnosed in childhood, one of her family affected by OI. She has a son who's age 7, just to give you some of the backdrop, and she was complaining of pains in her shins. Her bone chemistry was normal, her vitamin D level was low, but she'd been told that these were shin splints. She is ambulant, she does walk. We went on to do an isotope bone scan, but actually identified some stress fractures on top of the other abnormalities that were related to, on the scan, related to rods in the bones. So again, it's just having access to another expert isn't unhelpful. At the other extreme, a young woman called Stacey, not really, was referred by a colleague. She was in her mid-20s. She'd never had exposure to the diagnosis of OI, but her endocrinologist felt that she had blue sclerosis, she had a number of fractures in childhood, and the main thing that she was concerned about is that she had a 12-month-old child, and she wanted to know whether she had OI for the implications that her child might have OI. Having the kind of genie having been brought out of the bottle. And what was very useful there was I could liaise with Michael Wright, the geneticist, and we could chase up old x-rays, we could interrogate the dentist, and she had teeth that were poor quality but normal for Sunderland, and we repeated the DEXA scans, and there was no evidence actually that she had OI. Again, we can't just do a magic genetic screen. It has to be a clinical decision. It has to be about liaison with colleagues. And then for ladies of a certain age, and I'm beyond this, we have Veronica, who at the age of 48 starts to have hot flushes and is struggling in the workplace. And she's got postmenopausal changes or perimenopausal changes affecting her lifestyle, and we can discuss the role of HRT. Now, isn't that a long way from sticking rods into children's long limbs, shortened limbs, sorry, but it's an important part of the life course of adults with long-term conditions, and that's why I think it's important that we think about that journey. It's also an important time, and what I know is what I don't know, because I don't know anything like enough. In fact, I don't know anything really about the menopause in women with osteogenesis imperfecta. And yet, a lot of my clinical practice is the menopause in women who haven't got OI. So postmenopausal osteoporosis is a big part of our clinical practice in the UK, and we haven't got the first clue what the implications are for women around 45 and above. Just a point, and I've mentioned it already, DEXA becomes less and less edifying because of all the metal work, but again, we've just acknowledged that. Again, reference has already been made to bisphosphonates, and as I said at the front of the presentation, patients come and they're getting their regular bisphosphonates. They have a lot of faith in their bisphosphonates, and in the growing skeleton, that's clearly important. But I've got to manage help manage the long-term care, and I wouldn't give adults with osteoporosis bisphosphonates for 25 years. So we need to manage the expectations and the understanding of when the benefit is from bisphosphonates. This was reviewed by the Cochrane collaboration, and I guess their key observations, this was their review of bisphosphonates in childhood and adult treatment, adult life. There's clear evidence that you increase bone mineral density in OI, treating patients with OI, children and adults. It's unclear whether there is consistent evidence about decreasing fractures. The optimal method, duration of therapy, long-term safety are all unclear, and we should be looking at the long-term fracture reduction and quality of life indicators. And quality of life indicators are really important, I think. It's one of the reasons that we've moved in metabolic bone practice to giving more and more parenteral therapies, intravenous therapies and injections, because taking a bisphosphonate tablet daily, or indeed weekly as we do these days, is still quite an encumbrance on your life if you're going to take them for a period of time. So quality of life factors are really important. And I was pleased, I'm pleased not to be talking too much out of turn, because there has been reference to the concerns about bisphosphonates in adults and children and the risks, and we've talked about already from Mr. Fernandez has talked about subtrochanteric fractures. So these are fractures that occur towards the middle of the shaft of the femur. Even if you stick a metal rod in, you can still get that to occur. And again, we haven't had a spinal surgeon talking, but there is talk perhaps of getting unusual fractures in the pedicular fractures in patients on long-term treatment with bisphosphonates. So all this resulted in some 4 years ago, 3-4 years ago, as deciding, my predecessor treated all comers. I took on the post about 6 years ago, and I said, I'm not going to, I like children. I love children, couldn't eat a full one. I've got 4 at home, I don't need to see them in my clinic. Okay, so I said, I am not seeing children anymore. So all the paediatric referrals that hit my desk then went to the paediatric service and the genetic service. But equally, we developed a useful conversation about how we can transition care of young adults. And so it's still ad hoc more later, that we maybe have 2 or 3, 4 clinics a year where I catch the young adults at that perfect time. You know, the perfect time to take over the care of a patient is when they're 16. 16 is the perfect time. They're not truculent, they haven't got attitudes, they haven't got big decisions to make in life, and they haven't got any baggage about authority. So that's a really good time to meet a new consultant. But at that time is the time that we catch, okay? And it's nothing new. It's been done in in diabetes and inflammatory bowel disease and cardiology everywhere, and certainly we have good examples locally. It's also a really good time to review the status quo, because my wife's a paediatrician, so I can be rude about paediatricians. Paediatricians have a very different view of the world, and they're very caring, which, you know, is great. But part of my objective is to just review the situation de novo, which at the time of the people are entering young adult life is maybe not a bad time. And so we have a slightly different documentation. We just go through the story. We ask about family history, of course. We ask about fractures. That can take a very long time. We ask about previous treatments. We ask about whether they've had exposure to bisphosphonates and how long for, and dental treatment, all the things, and back pain, all the things that have definitely been addressed in their career through paediatric services. But we just take a problem list and saying what is important here and now. Just in reference to adult health, a couple of things. One is the heart, and I apologise to my patients and explain the context, but I generally arrange for an echocardiogram in young adults as they come into my service, and that's because, again, it's what we know that we don't know. There is some evidence it's not surprising with OI being a collagen disorder. There's lots of collagen in your heart, and it might be associated with some leaking in the valve of the heart. This is not heart failure. This is not coronary artery disease. This is not a worry. The reason I want to address that concern in young adult life is that somewhere along the line, later on in life, somebody might question how long a murmur has been present or a leaking valve has been present. So we generally do that, and there's some evidence of in adults with OI of some tendency for there to be some leaking in the aortic and mitral valves and some change in the size of the heart. Not a long-term concern, but I think in terms of establishing at what stage in the life course that happens, it's worth thinking about. Another thing is, which I find very refreshing, is how what evidence we have about quality of life in adults with OI. And to be honest, there isn't an awful lot, because we do focus on children and OI. But another Norwegian study which showed actually that people with OI, on average, were doing very well. They were mostly paired up, they had children, they were of a higher educational level than your average Norwegian, but lower employment. And again, that's understandable why people might not get access to employment, but it helps us also target some of those concerns. And again, one of the things I do get involved in is supporting people's applications to social services, local authority, housing, in the context of their long-term condition. Just an observation, really, the patients with any metabolic bone disease that comes on in childhood will spend most of their medical exposure in adult services. And I think it's just a time for us to look at that and how we can make things better. And we've mentioned bisphosphonates. In the growing skeleton, it's clearly the balance of effectiveness against safety is clearly in the arm of effectiveness. As the bones, the natural history, certainly for the less severe cases of OI, is that once people are past puberty and into adult life, the fracture rates really do level out. And it's whether we map practice in managing patients with OI to what I do in my adult clinic, where I preserve the benefits of anti-resorptive therapies, bisphosphonates, to the time when patients have got most benefit. That's when they're most at risk, you can get most benefit, and not to just treat patients who are possibly not going to benefit from the treatment. Again, with regard to those very rare adverse outcomes associated with the condition, problems at the base of the skull, are we asking the right questions? And we do keep that question rolling for patients who are at risk. Patients make sure they get a hearing test, so we know that we're starting with normal hearing, and as I've said, do an echocardiogram. There's also an opportunity for us to link up with clinical studies. So we're part of the Rudy collaboration. We encourage people to tell their story through Rudy. We're keen to look at supporting other studies through Rudy, through our clinic, and we've got a couple of intervention studies just about to start next month, again with the help of Dr. Wright and Dr. Bertoli. One is a sclerostin antibody study. I think you've heard this as other presentations of the BBS. But we have two studies that adults with OI will be invited to participate in. One is a 12-month study, one's a 24-month study. And so it offers a great opportunity for us to support that. Because if we don't have specialist adult services, where will it come from? Where will the evidence come from for the management of OI in adult life? So, I kept it brief, I think. We have paediatrics, endocrinology and rheumatologists. We have genetic services. We have specialist orthopedic services in the city, and radiologists. We've got 4 musculoskeletal radiologists. We have a metabolic bone clinic. We need to continue to develop, I'd say, our specialist MDT, we need to improve rehab, and we're not very good at that. We haven't got the infrastructure to support rehab for, I've got to confess, that we aren't very good at physio and OT in adult life. And again, that's one of the dreadful things that Sheffield does to us, is that they offer a fantastic comprehensive service, and then adults come to us, and it's really hard. That transition is something we need to manage. But the way the health economy is at the minute, arguing for extra services in terms of supportive care is really hard. We need clear pathways, specialist investigations, and we need to be developing the evidence for adults with OI that's been so effectively developed over the past 10, 20 years for children. And just, I suppose the latest news is, when I come back from our holidays, and when we persuade our managers just to tweak our job plans perfectly, we should be having a regular weekly specialist service for adults with metabolic bone disease with a genetic twist. I haven't really got a title for it yet, but anyway, that will happen with either monthly or bi-monthly clinics for a range of conditions, but OI is top of our doors, and I'll leave it at that. Thank you very much.